Hi all, and welcome to this case-based discussion about a recent example of a paramedic colleague in North Central London doing a really great and successful referral to our Silver Triage hotline. For those that are not aware about the Silver Triage hotline, I just wanted to give you a brief overview and to let you know that this is a really amazing opportunity to help support both yourselves with decision making about this complex, frail population, and to help the patient get the right care in the right place. All you need to do is pick up the phone and call the phone number that's on MyDOS. For any patient over 65 that either lives in a residential care setting or a nursing home setting, and you get to speak to a consultant geriatrician with loads of experience, and get advice about your patient, whether it be something minor or really a very unwell patient. It could be end of life patient, it could be something very complex, and the consultants will be really, really happy to give you advice and perhaps help you access some pathways that aren't normally accessible to you in the ambulance service. So this is just some encouragement to please use the hotline whenever you attend a care home in the North Central London area and see how it works for you. And we've had really great feedback. You're going to hear from Daisy in a minute to tell you about her specific case. And we look forward to more of you using it. And we look forward and welcome all your feedback.
Hi Daisy, my name's Simon. I'm one of the geriatricians working on the Silver Triage scheme with you and your colleagues at LAS. We're going to talk about one of the cases that we discussed together a few weeks ago. But first of all, could you just tell us a little bit about you and your background?
Yeah, I'm a paramedic. I've been a paramedic for 7 years. I was a student paramedic or tech for a couple of years before that. I started my career in Central London, and now I do most of my shifts up in North Central London.
Great. And we discussed this chap together a few weeks ago. Perhaps you could just do a quick kind of summary of what happened.
Yeah, so we were called to a gentleman in his 90s in a nursing home, and this gentleman was in a nursing home largely because of his frailty and his age. There wasn't anything specific that he was there for. He wasn't known to be end of life. We'd been called that day because he had suddenly had an absent episode, which had never happened before, which is out of character for him. And when we arrived, it was like he had no history of epilepsy, but it was like he was having an absent seizure. His eyes were fixed and straight ahead. He wasn't responding to us. His observations were okay, except that he was very obviously in Cheyne-Stokes breathing pattern, which, talking to the staff who knew him quite well, they said that wasn't normal for him. We looked into this gentleman's medical history, and he did have a history of cancer, breast, kidney, and skin cancer. And whilst we were discussing what to do, because we didn't know what to do with this gentleman, he suddenly came out of it and then went back to what the staff said was his normal baseline. He was able to talk to us. He was a little bit confused, but not new for him. But the one thing that remained was the very prominent Cheyne-Stokes breathing pattern, which we recognise as being not a good sign when it's in the acute setting. So we decided, when we were deciding what to do, to give the Silver Triage ring, because this gentleman wasn't known to be end of life, and we didn't know whether we would have much success if we were trying to talk to the GP if this gentleman was maybe now suitable for palliative care rather than active treatment, which is why we rang you.
And just before we talk about that call with your colleague on the road, what would be the normal response? I'm guessing you probably would have had to scoop and run, really.
It's a very hard one. So if we had no other options, then we probably would have had to take him to hospital, because we just didn't know what to do to treat him. He wasn't in active seizures. So we did consider calling a GP, but historically, and this is just personal experience, knowing the trying to refer to GPs in that area before, for that particular nursing home as well, I've had difficulty. and my crewmate has had similar experiences. So we probably would have tried to refer to the GP first, but we weren't very hopeful we would have had a successful conclusion that would have kept this gentleman at home. So I think ultimately our outcome would have been that we would have taken him to hospital.
And to be fair to GPs, you know, it's really hard for them to respond with the urgency that you guys need, because you kind of need a relatively immediate response, don't you? Minutes rather than hours, which...
And it is difficult as well. He hadn't seen his GP very recently because although he had these several comorbidities, they'd just been in the background. He didn't have anything that was very actively being treated by the doctor at that time.
So we spoke, and you summarised the story really nicely, and I think we both felt that this was probably an end-of-life scenario, some sort of intracranial catastrophe that was resulting in seizures and Cheyne-Stokes breathing, and thought that he might be dying. And then you were really brave, weren't you? Because you went and had a conversation with him and I think his sister, who was also in the home.
Yes.
Do you want to talk a bit about that?
So this it was very sweet. This gentleman was in his 90s, and actually in this same nursing home, the person in the neighbouring room was his sister, his older sister. So they very much wanted to be together for as long as possible. Because of his sudden change in condition, the patient wasn't aware that this is possibly a kind of pre-terminal signs and symptoms. So we had to have a very difficult discussion with him and explain what was happening. But I think it was an important discussion because part of that conversation is we said to him, what do you want? We want you to be involved in this treatment. We want you to have the outcome that's the best for you. So we did ask him, where would he like to die? Does he have any preferences? And through that conversation, he communicated with us that he wanted to stay with his sister as long as possible. He wanted to be in a nursing home. The staff were actually very good and they knew him, so they were happy with that decision. And we did ask him if he'd like to be referred to a hospice or if he'd like any other teams involved, but ultimately it was his choice. And I think that was really good for the patient. He got what he wanted.
Yeah. A really nice example of what we call shared decision making, or focusing on what matters to the patient, which is obviously what we're all in the job for. So yeah, it was really, really well done. And we managed to get hold of the GP. I think I went off and spoke to the GP who was actually really responsive and supported with end-of-life meds and was due to follow him up either the same day or the next day, depending on how things played out. So in the end, I think a good outcome. You know, a difficult scenario, but the patient ended up with what mattered, you know, saying where he wanted to be with the treatment that was relevant to him. From that scenario, anything that we could do differently or better with this scheme that you think could help us improve how it works from your perspective?
I think just getting it known that it's out there. The GP was very responsive, and actually after you spoke to them, they called the home straight away and then had a video call with the patient whilst we were there. And they were able to get this treatment pathway rolling for the patient. But I don't think they'd heard of the scheme prior to you calling them. And I think they would be very much more receptive to talking to you again and taking your referrals again. But just, it's such a valuable resource. And I think that we should be taking it up and keeping these risk patients out of hospital as much as possible. It's not always the best outcome for someone in that stage of their life to be going onto a hospital ward where it's just not the most appropriate place for them.
Yeah. So hopefully this little video will be useful kind of awareness raising so that we can share with colleagues and get more people using it. So Daisy, brilliant. Thanks ever so much, and enjoy the rest of your day.
Thank you very much. Take care.
Cheers.